I direct said forum, which is an initiative of the Humanities program that brings in speakers, scholars, journalists, experts, artists, etc., from around the country, around the world, to introduce you to their research, ask some big questions, deepen your appreciation for the humanities. Today's one is something we're really excited about. We've got this nice collaboration going on with the School of Nursing and Health Sciences, because we think it's especially important to bring a full understanding of the human person into medicine and into the health sciences. And so we're very appreciative of SNHS's support of these sorts of events. In a minute, I'm going to turn it over to my colleague Gina Noya, who's going to turn it over to the speaker and introduce the speaker. Let me just lay down the expectations and ground rules for you today. Number one, close those laptops down, put those screens away. We've got pen and paper. If you need to remember something and write it verbatim for your class next week or something like that, I'll post the video for you. Don't worry about it. You don't need your laptop out. Rule number two, a student has to ask the first question. Because, you know, we have the talk, and at 45 minutes or so, it becomes Q&A. Don't wait for a professor to say something. We're not saying anything. So you think of a good question. And then rule number three is really more like a suggestion. We have a reception down the hall in the great room. It's nice. So if you're sitting and thinking, this event is great, I just wish there were some teriyaki meatballs, we got you covered. Just go down the hallway right after the class, okay? Okay, with that, I'm going to turn the microphone over to Dr. Gina Noya.
Hallo everyone. I'm going to introduce the speaker for today's Humanities Forum. Speaker today is Anna Halpine, who is the founder and CEO of FEM, a non-profit organization committed to women's health. She has been involved in human rights, women's health, and global partnership development for the past 18 years. She founded the World Youth Alliance and was the WIA president from 1999 to the spring of 2007. Originally from Canada, she currently lives in New York City. She holds a master's in philosophy of religion from Yale University. I am very excited for Anna Halpine to be with us today. I've known Anna since I was your age. Back in the day, I actually worked for WIA as an intern when I was an undergraduate. And so very excited for her to be here, so please join me in welcoming her today. Thank you.
I've got this one. Thank you, Gina. Thank you, everyone. Is this on? Yeah, you can hear. Okay. Great. Well, I really appreciate the invitation, and thank you to all of you for taking the time today to come. As Gina mentioned, this is really going to be a talk about how I got involved in women's healthcare and the kind of healthcare that we think needs to be available for women in the United States and around the world. But I want to start, because this is also a humanities lecture, with where we began in the consideration of these ideas and where this process started for us as well. So this is a quote from Václav Havel. Many of you might know who he was. He was a dissident, a resistance fighter. He became the first democratically elected president of the Czech Republic after the fall of the USSR. And Václav Havel wrote a very important and famous essay called The Power of the Powerless. And in this essay, he really asked this central question, which was a story of what everyone in Czechoslovakia at the time and all around the Iron Curtain were living. Václav Havel talked about the famous greengrocer, and he said the greengrocer is placing a sign among the tomatoes in his store, and the sign says, "Workers of the world, unite." And one day, the greengrocer starts thinking about this sign, and he begins to ask himself, what does it mean? What do I think? Do I agree with this sign? These are now very dangerous thoughts. The greengrocer knows that as he thinks these thoughts about the sign, he will have to decide whether he keeps the sign there among the tomatoes. And he knows that if he removes the sign from his store, his store will be closed, he will go to jail, his children will not be allowed to continue their education, and there will be a significant price to pay. The greengrocer keeps thinking about all of these things, and one day he removes the sign. All around the Soviet Union and in the Czech Republic, similar things are happening, and the greengrocer decides, whatever the cost, I will live in the truth. And that is, I think, the starting point for the humanities. It's certainly the starting point for the question that we ask ourselves, which is, who is the human person? And I think Václav Havel gives us a very powerful answer here. The human person is someone who must live the truth. And so the pursuit of the truth is central to our lives, and of course that's the motto of this university. In 1999, as Gina mentioned, I was a music student at the United Nations. I was at a conference on population and development. The question in front of us was, how can we help the most poor around the world? What does development look like for those who are suffering and struggling the most? And the answers were not adequate. The small group of young people were brought in by the United States government at the time. They were given the floor. They stood up and said, we represent all 3 billion of the world's youth, and these are our demands as young people. They demanded abortion as a human right, sexual rights for children, and a deletion of parents' rights. At a conference on population and development, there was no mention of development. There was no mention of the needs of the poor. So I went back into the UN with Dayglow pink flyers. Some friends and I had made them that night. We broke the rules, gave these to all of the assembled delegates. That caused pandemonium. For 2 hours, the negotiations were stalled, and the world divided. The Western states huddled around the US delegation, but the developing nations came to us one by one and said, thank you. Thank you for being here. Thank you for saying these things. And thank you for presenting a different vision and idea for how we could build societies around the world, societies based on the realities of the dignity of each person and the needs facing each human person. The next year we went back to the UN, and there was another conference, this time about women and development. And at this conference, at 3 o'clock in the morning, when all the difficult negotiations take place, the United States delegation proposed a very short oral amendment, which I have here. This very short oral amendment, not put in writing, simply stated, human rights grant human dignity. Think about it. Human rights grant human dignity. We think a lot about human rights. When we think about human rights, we think these are good things, generally. But this phrase is the exact opposite of the Human Rights Project. The Human Rights Project is rooted in the entire post-war structure, and it is rooted in the Universal Declaration of Human Rights, which says in the first sentence, the dignity of the person is the basis and foundation of human rights. What that means is that law, member states, politicians, the powers of the world are obligated to respect the human person and to make laws that respect the human person in order for those laws to be just. This is the reverse of that. It says human rights grant human dignity, which is the very dangerous temptation of all time, certainly of the 20th century, which reverses that because human rights are legal instruments that bind states. And so what that means is the state can determine who has human dignity and who doesn't. The exact opposite of what we want. We all know that what the state can give, the state can take away. And that is, of course, the whole foundation of the many human rights fights, the many wars that have been fought over the last 100 and more years. Coming out of Nuremberg and the catastrophe of the Holocaust and World War II, this was reaffirmed in the modern Human Rights Project that the dignity of the person is the foundation of human rights and that each of us must know this, and we have a responsibility to respond to the human person regardless of what any law or power might otherwise suggest. So very quickly, we recognized that we had this moment at the United Nations. We had these statements that were the opposite of human rights. And we had this opportunity, this possibility as young people to respond to this question, which is the question that recurs over and over. Who is the human person? Is the human person a subject or an object? Is the human person the subject of human rights, or is the human person an object that can be used or destroyed at will by individuals or states? So a few years later, we had opened an office in Africa, and Kenya submitted their report on human rights to the United Nations. And the response to that report was that the human rights evaluators in New York were very concerned about human rights and women's health, in particular, in Kenya. And they basically failed the Kenyan government in this human rights report because they said that Kenya was not providing sufficient sexual and reproductive health services and contraception, especially in rural areas and to the poor. So this is a very serious thing for the Kenyan government to fail their human rights report based on these violations of women's health, so-called rights, in their treaty document. Then the committee said that Kenya must ensure basically free contraception and safe abortion in order to pass this human rights review, and that this was the only way they could be in compliance with their treaty obligations that they had signed with the United Nations. So then we have to say, what does Article 12 of this treaty actually say, such that Kenya could be in violation of basic human rights in submitting this report? And this is the treaty that Kenya signed, and you can read it quickly, but what you'll see is that this is a treaty about the provision of basic health to all people in Kenya, which the Kenyan report was demonstrating that they had fulfilled. This includes reducing the stillbirth rate and reducing infant mortality, better health for the child, improved hygiene, prevention of disease, and conditions that enable the expansion of medical services. This is what Kenya had signed. This was what the report said they had done, and yet they were being accused of violating human rights because of the non-provision of contraception and abortion for free to the poor. When you look at UN documents today, the important point is that UN documents themselves recognize that while we want to encourage health, and women's health in particular, because of the importance of women's health for communities and families, women's health and reproductive health does not include abortion. That is specifically written in the documents the UN itself has promulgated over all of these decades. So if we think back to the beginning, we have to face this question. Here is the question of the human person at the heart of human rights, the question of the human person at the heart of healthcare, at the heart of everything we do. We want to say, here is the human person in front of me, this being that has inviolable dignity, that is worthy of rights. We evaluate the justness of a state based on the justness of the laws and the protection that they offer to the most vulnerable, to the poor. And so how do we get into a situation where we are now not talking about the service of the poor, the service of development, but talking only about abortion as an international human right? Then we had a similar situation with the Philippines from 2011 to 2013. We entered a similar debate in this country with the contraceptive mandate for Obamacare. And in June of 2022, that debate continued to get heightened here in the United States with the Dobbs decision. And I think we all know this. And so that leads us really to the next question, which is there a way forward? Is there a way out of this reality we all live in, especially that you live in, of this highly politicized world and the politicization, as we can say, of both human rights and the human person and women's health. And the answer to that is what I would like to propose to you. What we have done is to try to go back to first principles, recognizing the dignity and reality of the human person, especially focusing on the dignity and reality of women, and asking ourselves, what should women's health look like? And can we find a new pathway and a new answer through these problems by reprioritizing the human person and finding a way that answers the needs we are facing in a way that better respects everyone and everyone's dignity that we're looking at. So we learned that in policy, in these debates, it's not enough just to debate. It's not enough to have one position or the other. Policy really moves forward when we can find a way to put these ideas into practice and to offer a new solution as we move forward. And so having gone through these debates, having looked at what we were offering, having on our side evaluated them to be inadequate at best and divisive at worst, this led to the development of a women's health organization called FEM, and I want to walk you through what that looks like. And I hope that the answer or the idea that this will give to you is something very exciting, where we have really seen that the science now exists that can move us into a different direction, a science that really allows us to put the human person at the center and build a response enabling us to move forward. In the policy work that has been done, and when we again look to the global human rights projects, the first principle that has to be in place if we want to offer health that respects the human person is the principle of informed consent. This means that people know what they are being offered, they know what they are choosing to do or to receive, and they have the ability to move forward. This engages, as we remember, the idea of the truth about the human person and the goals that they have for themselves. And now I want to move into some science and say to those humanities students who went into the humanities to avoid the sciences, don't worry, we can get through this together. I have also learned this. So when we talk about women's health, I want to reposition this conversation and maybe state the obvious, but state it in some of these scientific phrases, which is when we talk about women's reproductive health, we start with the brain. And women's health begins in the brain, and the brain is the control center for women's health because women's health is really directed by signals from the brain, called hormones, that influence and interact with every organ and system in our bodies. So we are not just thinking about the reproductive organs, which is maybe how we've traditionally thought. We're starting with the brain. And really what we are doing is we are engaged in a little bit of a dance. So on the top, you'll see we're going to take a look at the interaction of the 4 reproductive hormones. And at the bottom, you'll see a hormone graph that shows you the relative amount of each of these hormones that's needed for the next phase, the next steps of the dance to take place. And what you're really going to see is that this is a dance. It's a communication between the brain and the organs. And they talk to each other as these hormones change. So we have the first signal, which comes from the brain, the FSH, follicle-stimulating hormone, and that then talks to the ovary, which produces estrogen inside the follicle. If estrogen rises, the delta of change is what's interesting here, then it will talk to the brain, calling this second brain hormone, the luteinizing hormone, to do something which is very extraordinary in nature. Nature likes negative feedback loops. Nature tries to avoid explosions. And the LH hormone is one of the few hormones that is an explosive hormone. It's like the TNT of hormones. The purpose of LH coming from the brain is to rupture, to cause an explosion, and that rupture is ovulation. And so now the empty follicle inside the ovary is producing progesterone. So what's important here is to say the brain causes the ovary to produce estrogen. And then the brain ruptures that follicle, and now the ovary produces progesterone. They're like gear shifts in a car, and what we want to see are these very specific amounts of hormones that are rising and falling at various points of a woman's cycle. When that happens, all of her organs are functioning as they need to be. That means that her organs are working. It means that her bone density is forming. It means that she has the energy to do what she wants to do. Each of us, it means we can get out of bed, go to the gym, study hard. All of this activity focused around that ovulatory moment, when it's working well, is giving us the ability to accomplish the goals that we want. And very importantly, when these hormones are working well, our well-being and our sleep is also working as we want it to be. Currently, our standard of care for women all around the world is to say whenever anything goes wrong in this process, whenever any standard symptom, which probably most of us in this room have experienced, symptoms like brain fog or symptoms like migraines, pain, too much bleeding, too little bleeding, acne, weight gain, weight loss. Whenever we have those symptoms, the standard of care that is promoted all around the world is to provide a hormonal suppression for women. It improves those symptoms, but what it does not do is diagnose and treat why we are having those symptoms. And that's the advance that I want to talk about now, because the question we can ask ourselves is whether we want to get stuck in the fight where women's health has become this political ping pong that goes back and forth, or whether we can say, can we do more, can we do better for women themselves? Do we have the science and the clinical knowledge to actually diagnose and treat all of these symptoms that women experience every single day? And the good news is that we do have this knowledge, and we can also make this available not just to women in the United States, but to women all around the world. And I want to very briefly show you what that kind of knowledge is, what it looks like, and how we are working to make it accessible and available to women around the world. The FEM app is free. You can download it. That's a way to start understanding your own biomarkers and body. But I want to really spend a few more minutes walking you through these advances in healthcare, primarily in the field of reproductive endocrinology, which really means the hormones that drive all of these processes, so that we can understand what the science has today and where we can see the ability to pivot or move in adjusting how we might approach women's health. So when we start with a patient at FEM, when we take this knowledge that is now existing, first we want to say, are her biomarkers? This is the woman's own informed consent, where she can learn to understand her body, create her own pattern of biomarkers. Are those biomarkers physiologically normal and healthy? And these are guidelines that we know from science. Many women will say, this is normal for me, this was normal for my mother. That is true. But physiologically speaking, we know that these are the types of numbers that we want to see in each of these phases of the cycle, and women can learn to identify and know this for themselves. So a woman is the first agent in her own healthcare. She learns to understand her body, and she becomes an advocate for herself. And she brings that knowledge to her own provider. Then we take a look at what is now a standardization of advanced reproductive endocrinology. We're going to take a look at blood levels of over a dozen hormones so that we're getting that snapshot of what's happening inside a woman's body to get to that root cause of what she's experiencing. So we have the pattern that she provides, we have the blood levels that a blood draw can offer, and then we have ultrasound imaging, which can show us what's happening inside her organs, her ovaries, and her endometrium. And all of that become the tools that allow us to then diagnose and treat the symptom that she herself presents with. And here's a very common symptom, and this is acne. And I just want to point out in the gray box, maybe you can see it, maybe you can't, but there are over 9 hormones that we need to assess that can be singly or in combination, the cause of that acne that she is experiencing. And so the point here is that the woman's body, men's body do these same things in different ways, but our bodies give us signs and signals. We know we don't want things this way, and we need to have a healthcare response that allows us to take that information and respond to the needs of the patient in front of us. And the good news is that we have the science to allow us to advance in these ways today. Finally, I want to pull this together. On one side, on your right hand, you can see different charting patterns. These are real women's patterns. This is how they experience their own hormones and biomarkers. And these patterns then allow us to move backwards in understanding what is going on to create those patterns. So here we have patterns at the top. Gray essentially means dryness. And you all can understand at this point, this is a woman who is not having that ovulatory cycle where those hormones are moving. And she will have symptoms as a result of that. Moving to the left, we can see that her reproductive hormones are low. That makes sense to us. If your hormones are low, we're not having all those fluctuations necessary for ovulation. But the missing part for women is really the next step, which is what is causing that cascade of low hormones. And when we can identify that cause, that primary cause, then we have a diagnosis. And you can read those diagnoses here, and you can see that they're all different. And we know that we need to treat these things differently. And this has really been the challenge in women's health. For instance, we know that in the United States, the leading healthcare country in the world, the most common condition that women experience is something called PCOS, polycystic ovarian syndrome. It's a symptom that's related to what we've been talking about. And the standard timeline for women in this country to get a diagnosis, that's step 3, is 8 to 12 years. And perhaps some of you have experienced that yourself. It's a very frustrating process. And the good news is that it is not necessary. We can move through this process in a matter of weeks. We can get an accurate and sensitive diagnosis. And once we get that diagnosis, we can move to the right kind of treatment so that we are restoring health, we are addressing the symptoms that the woman has, but 2 very other important things are taking place. Number 1, we're improving health outcomes. Women don't want to be receiving Band-Aid solutions for their health care that allow the underlying circumstances to worsen year over year. And women don't deserve that either. So the good news is we have the science, we have the ability, we can diagnose and treat, we can move towards that diagnosis in an efficient and quick way, and this allows us to improve women's health outcomes now, and improving them now improves them for her whole life. That improves her future fertility prospects, and this improves intergenerational health. So going back to where we are now, I just want to say this is the pathway that we have gone through, starting with the human person, the dignity and reality of every human person, seeing these fights, especially around the issue of women and women's health, really prompted us to say, can we do more? Can we go deeper? Does the science exist? Has it already been clinically developed? We don't want to experiment on women. And the good news for all of this is the answer is yes. The science is available. It's known. We're now making it accessible. We're making it affordable, and that's true in the United States, where we have the ability to receive patients, use your own insurance. It's true in Africa, where we're seeing this grow quickly. It's a care model that prioritizes the person in front of us, the time it takes to understand what's going on, to get to the root cause, and to take care of each and every human person and the human family in the best way that we have. So thank you very much. I'm happy to entertain any questions you might have and open the floor for conversations. Thanks a lot.
So I'll bring the microphone to you when I see the hands.
Hi, thank you so much. That was all so interesting. My question is, a lot of the technology is very digital based. So how do you reconcile that with lower income areas, especially when you're talking about taking this on an international level and reaching those more rural areas that might not have the infrastructure for this kind of technology?
Thank you. The first question is always great, so thanks for being the brave first question. Here in the US, the digital access is working well, and one of the things that it solves is limitations of healthcare access, especially for specialist or specialized services, particularly in rural and under-resourced communities. So that's one of the things we've realized with building our telehealth network, is that we can really make this available to every single patient in the US that wants it, and we can continue to grow with those patients as that demand arises. And we've just seen our inability to keep up with that demand. We are doubling plus this year and on track to keep doubling next year. So we'll see about 9,000 patients this year. We aim to see about 20,000 next year. So it's really as much as we can do to identify and train excellent healthcare providers who are excited to offer the women and families they serve more, and to bring this to communities all over the US. And here in the US, we have really found that everything that we want to do, the blood draws, the imaging, the testing that we want to do, the medications that we prescribe, all of that is covered by both public and private health insurance. So this is an excellent way for us to make this option available to women and families who want it. Your question, I think, is maybe a little bit about that, but then what about Africa? How is this working? We had the same question. It is overwhelming for us, the response that we are seeing in Africa. And again, I want to really emphasize that one of the powerful things that we have seen in this process is that this is a response to women's health that is essentially time-intensive, knowledge-intensive primary care. And I think that's really helping us to rethink how we should be giving primary care. But this makes it a very effective medical and clinical offering for low-resource settings. So in Africa, we have a partnership with an amazing hospital in Tanzania. And this hospital has now fully integrated the clinical protocols that we use in their medical residency program. They are the ones cascading this to very resource-poor settings. They know the local languages, they work with those local clinics, but it is really working. The hospital we work with has a catchment area that serves 20 million people in Tanzania alone, and they have really been able to transform the care they offer. Before FEM, they could diagnose and treat 40% of the women who ended up in their urgent care. Post-FEM, they're now at 95%. They're looking to implement the final labs that are difficult for them, and they say we're going to get to 100%. It's preventing longer stage, later stage disease burdens. It's preventing more difficult to manage later maternal health morbidities and mortalities. It's allowing them to identify women who need extra care earlier. It's completely transformed their fertility outcomes. And so now this year we had our second training in Africa. We had 56 OBGYNs from 9 different countries representing multiple hospitals and hospital systems. Many of these worked over the past year to integrate these protocols in their hospitals. It's working. They have the labs. They have ultrasound machines. They have access to the basic medicines. And where they don't, we're working together to understand and do the research that they are fully qualified and able to do to figure out the adjustments. So I think that's one of the additionally exciting ways that we've seen that here we have some answers that are answers individual women want here in the United States. It's transforming their lives. It helps them to accomplish their own goals. And we can bring this to women everywhere. So it really is accessible. In Tanzania, they have translated the FEM app into Swahili, and most women in rural areas have access to phones. So that's been one of the ways that they've kind of jumped over lack of standardized infrastructure. The phone system allows them to just connect where they can when they want to, and women are using these phones in villages all over Africa.
Thank you so much for being here today. How has the uprise of GLP-1s prescriptions been affecting women's health, specifically PCOS and endometriosis?
Okay, well, so I'm going to first fall back on the fact that I was a music and philosophy student. I know there are highly qualified medical researchers in this room. But very briefly, I think everyone is aware of, for instance, the headlines of GLP-1s, Ozempic babies. We've seen that. And we've seen that in our own practice here in the United States. So I think in our hands, let's say here in the US, this is a treatment that we use a lot, especially for certain conditions of PCOS. We subdivide our PCOS patients into 4 different types. So again, a lot of the work that's necessary here is to take the research that is happening, put it into the hands of clinicians, and help them get the most sensitive diagnosis they can. So there are many kinds of PCOS. The more we understand the specific diagnosis of the woman in front of us, the better we can take care of her. But GLP-1s are a part of caring for some of those PCOS diagnoses that we've seen. And we also know that the earlier we diagnose and treat, the better the outcomes are now and in the future. That's for her, and like I said, for her own future health and fertility goals. And the healthier the mom, the healthier the baby. The final thing I just mentioned about that is that we love treating young women. And the reason is twofold. We want to provide health care to women when they need it. So we don't want women suffering for 15 or 20 years with symptoms before they get the health care they need. But the second reason is very related to that. And that is that, remember, the first point that we want to rearrange in our minds about women's health is that women's health really starts from the brain. And brain plasticity is a very important part of healthcare, especially for women. So puberty, which for women is usually about 12 or 13, opens. The whole point of this process is to mature the hormonal axis. And the brain is part of that process in a very intricate way. And brain plasticity closes for women around 24 or 25. And what we are seeing is that when we can diagnose and treat women early, we can sometimes help to teach the brain what we actually want it to be doing. And this really helps that individual woman and, let's say, her children to have that stronger hormonal balance and healthcare locked in place. So before 25 is a wonderful time to diagnose and treat. It's a critical time where each of you do establish this baseline of your own health. But the brain science that's really opening up to us in a very special way right now is helping us to see these additional critical areas of importance to taking care of our young women in particular. And that we have this additional opportunity to teach our own brains how to help us manage our health for the long run.
Hi, can you hear me? Thank you very much for being here. I've been teaching fertility care for 24 years, and so I think it's super important. Could you connect the dots between the importance of a woman understanding her fertility for her personal health, and also connect that to how you introduced it, so in terms of contraception and abortion, and how that answers the question of what they do?
Yeah, thank you. So I think the question, or this will be my attempt at an answer, is really understanding your own body as a central aspect of empowerment and knowledge. So women have the ability to almost see inside. And the way we can see inside our bodies is to understand what these hormonal changes are that are happening. And so we can learn to do this by charting those hormonal changes, understanding these biomarkers, and creating the patterns of our own particular chart, our own particular fluctuation and mediation of these hormones step by step over a whole cycle, cycle after cycle, to understand for ourselves what's happening in our body. This is, for most women, very transformative. It moves away from ideas of maybe shame or trauma even that have happened to us towards understanding the reality of our bodies, the order that we can understand, and to see all of the abilities each of us have to take care of our bodies, to influence our bodies and our health, and to know who we are. So understanding and learning our own bodies, understanding these charting patterns, really, I think, transforms for many women the concept and understanding of our own selves and who we are. Understanding our health and understanding fertility as a possible central part of that health, and protecting and knowing how we can manage that is key. So as we saw, that's very related to how we want to manage our bodies and how we want to think about these other ideas that you've mentioned. But the second part of that we've really seen with FEM, and that I think we felt was a missing aspect of that, is what if my chart is showing me what I already feel? What if my chart is showing me that I don't feel great, and my chart confirms that? What if my chart is confirming for me that I'm not ovulating, or confirming for me that I have all these symptoms, and that makes sense because my chart is full of symptoms, or I can't understand it. I can't learn to chart because it's too difficult to see what's going on. Our experience is that if it's difficult to learn to chart, if those symptoms you're experiencing are showing up, if you're trying to understand these hormones and it's not clear, we need to be able to then work with that woman, young woman, old woman, and we need to be able to correct that health. And that, I think, has been the missing piece. How do we get that health care working? How do we restore her own cycle so that her mental health, her physical health, all the actions of her health are clear? We get that cycle working the way we know physiologically it should be. And in that process, she's engaging with her own body, her own health care, but she should also be feeling better. And so I think that's the missing part that we've recognized. We don't want anyone to say, this is the curse of being a woman. Our physicians say there is no symptom level that's normal. That's sometimes the most shocking thing for women. When we speak to young women, they'll say, well, what do you think is normal for cramps? What's kind of normal for the amount of pain I should be taking on these days? The answer is nothing is normal. Symptoms are not normal. And so then we think to ourselves, this is a heavy burden that young women are carrying. They have physical symptoms, they have emotional symptoms, they have mental health symptoms. And I think the main message I want to leave you with today is that symptoms are your sign. It is your body talking to you. And we want to respect and listen to that sign. But now you need to find a medical provider who is trained to walk with you to try to diagnose and restore your health and not continue to mask those symptoms if that's possible and if that's what you decide you want to do. But I think for the vast majority of women, they learn to chart. They find challenges in the charting because they're already struggling with symptoms that they know are related. And then they have the third challenge of finding a medical provider that they can trust and work with to try to get to the root cause of what's going on. And the telehealth option has been our best way to make it available to women to say, if you want to live this way, we can walk with you in this sense. You can log on, use your insurance, talk to a doctor, and let's work together to restore your health so that you feel confident and happy and clear, and you can get back to doing what you want to do. For many of you, that's going to be sports, school, hanging out with your friends, having that energy, not spending so much time managing pain, symptoms, other difficulties.
And I have a question. So you've described a health paradigm which, on the one hand, your friend is offering us a way out of this sort of like politicization of reproductive health, right? And on the other hand, it's saying like, it begins with you in person, with the individual, with being responsive to them, et cetera. None of that sounds controversial. Could you elaborate on what are the challenges, the roadblocks that are preventing or inhibiting the FEM approach from becoming sort of the dominant one? Does that make sense, this question?
Thanks. Yeah, Ian, I thought professors were not going to ask questions.
No, only the first one. Now it's open
Okay,
season.
okay.
So, and I've got the microphone.
Obviously, there's a lot of controversy, so I tried to touch on the real hot button issues and say that really triggered the thinking for us to say, is there another way forward? So first, I can reiterate those. Abortion, contraception, these are real hot button issues, but we also don't think these are the only things that should or even are part of women's health, and I think that's been a huge problem we've faced. You think about women's health, you think abortion and contraception. So it's really important for us to say that's not true. And it's also important to say the knowledge that's baked into the work we're doing at FEM is decades old. And maybe a third thing that's true is to say we knew the science that's at the root of FEM, and we knew the clinical application that is the clinical protocols we are using before we knew the possibility, or let's say the ability, to even create hormonal contraception. Because this science had to be understood, discovered, and developed in order to use that science to, let's say, turn these hormones off. So that's, I think, another way of thinking about it, is that we are moving back to the science itself and making the clinical practice of this science available. And so what are the roadblocks? The roadblocks, let's say, taking away some of the battles that are real. I think you want me to maybe lean into the fact that there are people who don't want to see an offering for women's health that doesn't prioritize contraception or abortion, or perhaps include it. We think that is widely available. And there are many reasons to be opposed to that, not just scientific, but there are scientific pathways that can also say on their own, there is a new way to take care of women based on the science alone, and we think that's a legitimate claim that we want to make available for people to have the option to opt into. So our challenge is, let's say, twofold in different places. Here in the United States, we need to train medical providers. And one of the things that we're seeing is that it is very easy, let's say. It's reasonably easy, and it's exciting to train young medical providers. That's nurse practitioners, physician assistants, medical doctors. When you have the opportunity to train a young, smart person in the ways of the knowledge that we have up front, they are like ducks to water. Everyone in this room knows that. If you can learn something now when you're young, when you're eager, when your brain is engaged, and you can learn something that you want to learn first, you can really apply that directly. So here in the United States, we offer programs to offer this training to people who've already been trained, because it's not available in existing healthcare training institutions. But we hope to make the case to institutions over time that this is a specialty pathway that can be offered, or we can collaborate with people to make that available. In Africa, what is so exciting and transformative is that the health institutions and the medical schools themselves are responding to this. And they have taken this into their schools. It is a very straightforward way, and the medical students love it, and the hospitals love it, and they're just getting better health outcomes at every stage, and everyone loves that. So standard problems, let's say, that we are facing right now are good problems. We're facing the problem of growth. We're facing the problem of building a process that makes it easy and accessible for people to access this. Currently, we have over 700 patients on our waiting list. So we have to do a lot of growth just to get through that, and then even make it possible for people who want to access this care to do that. So our experience is when we can make this available, people love it. Families, individuals, women are waiting for this. And most of what we encounter is women saying to me, "You've just described my experience. That's what I've been going through. I've been trying this process already. I've already been to 4 or 5 different doctors. I've already tried all the diets. I don't know what else to do. And when they know that there are new options available, our waiting list and our experience says, yes, women are interested in that. They're looking for it. And so even as a process of access, this is something that I think we need to make available. So we have a lot to learn and a lot to do to make that grow, but that's the challenge that we're in and currently facing.
Hello. Sorry. Hello. Thanks for coming. So my question is, do you think it's important for like the average guy to know about this stuff? And if so, why? Cause?
Thank you. Yes. So to all of the men who are here, especially those who didn't have to be here, thank you for being brave and for coming. Men absolutely need to know this. Most men have sisters, a mother. Many men will have a wife. On our FEM platform, we treat a lot of men. When we treat a couple for fertility, we treat the man and the woman. So many men are our patients. Men have all the same hormones as women, just in different levels, and then those levels are constant. Our medical research director was just giving a course, an advanced course to our doctors last weekend, and she was talking about one of the controversies in medicine that's happening now. Many of you might have heard of it, but it's the reality that many drugs and many procedures are not tested on women before they're given to women. And so she was talking about the reason that that is. And she was saying, well, when we test drugs and different procedures, we start with mice and rats. We don't start testing on humans. And she walked through the process of what it was to work with male rats versus female rats. And she had spent a lot of time in the lab. So I won't get into all of the details, but for a female rat, you have to do all the work that you have to understand for a female mammal person. And she said you have to cycle them. So you have to like pull up the rat, you have to see where they are in their cycle, you have to put them in that cage so that all the rats are in that phase of their cycle. She said always somebody comes, they clean the cages, they throw them all back together, you have to start all over again. So it's a lot of extra work, it's more difficult, but it has meaning. So the fact of the matter is we know better how to treat men because men have all these same hormones, but these hormones aren't engaged in a dance. Women's hormones are dancing all the time. Sometimes those hormone levels are changing minutes to hours. That's the complexity of women's health, and that's the answer that reproductive endocrinology, this understanding of hormones, has given us for women's health. The great mystery that is now starting to be known by us. So the answer is yes, men need to know because men love women and they live with women and they work with women. And so we all want to share the burdens and help find the answers for the people we love. Men are part of the fertility challenge when that arises, and in that way they become our patients. But many of our patients are mothers, and as we start to treat them, they'll say, but my son has this. What you're describing, the symptom I have, my son also has that symptom. And in this way, those sons become our patients too. So we can treat young men and old men very well. We have specific protocols for that when the need arises. But we need to understand that for all of the reasons we've touched on, and again, if we sort of dig back into the more controversial and moral complexities related to contraception and abortion, women's health has been at the epicenter of these controversies. There are critical moral and other very difficult questions surrounding those, lifestyle, how do we navigate, how do we manage, but that has also resulted in this paradox that we talk about women's health all the time, and yet the reality is that women's health everywhere, here in Providence, in New York City, also in Malta or Nigeria, women everywhere face this unmet need for actual health care. And so we think of this as being an unmet need for those who are the most poor, the most vulnerable. That's true. But when we think about the kind of health care we want every woman to have, which is care for her own health and her own symptoms that gets to the root cause and treats that, almost every woman is living in that same kind of healthcare vacuum. And so that's where FEM started with women. Women, let's say, are on the tip of the sword of this debate. They're on that tip of the sword because of their unique biology, because of their ability to conceive and bear children. All these controversies, all these moral questions are there. But I think the missing part to this conversation has been, how do we also take care of women and women's health? And that's, I think, one of the areas where we can now solve for this in a totally new and different way. Thanks for your question.
Thank you for your time. My question was, how does FemHealth differ from other period tracker apps or other telehealth providers?
Thank you. So FEM's, let's say, period tracker, as you put it, or FEM's app can allow you to track your period. What we want you to know and to track is ovulation. So ovulation is the sign of health, and that's what we want women to learn how to identify in their own body and in their own self. So many apps can allow you to track this in many ways. FEM is also an app that can allow you to track that. So I think there are options in those areas. One of the challenges that's emerging in the femtech world is a different kind of challenge related to these kind of controversial areas. But most of the apps that exist for women are monetized by pharma support. So FEM is a nonprofit app. It will always be. It respects the privacy of women. We don't sell your information or data to marketers. We don't try to sell their products to you. And that changes the app. One of the reasons that the FEM app exists is just for women to have access to the science and management of their own bodies, and to have that available for free through the app and the iPhone store. So most of the common apps that many women are using are now very sex promoting, they're very pharma promoting, and they have all sorts of other aspects. But if you find those apps are working for you, there's no need to change. I think what FEM is using telehealth to do is the difference to your second part of your question. Telehealth is a tool. COVID made this available to all of us. We all learned how to do everything online at that time. And what we recognized was that telehealth was giving us this powerful tool, allowing us to provide this kind of clinical care in an affordable, accessible way all over the United States. So we've continued to lean into that. Telehealth itself is just the way that a patient and their medical doctor link. But because a lot of what we're doing is sending you for testing near you, sending you for imaging near you, this is really a way that we can maximize that provider impact and keep it affordable and accessible to as many women and families as possible. So for us, it's a tool, and it's really allowing us to grow at a rate that's affordable, and that's, I think, good news for women and good news for the women who want to access this.
We've got time for another question or two, if questions there be.
First off, I want to thank you for sharing this information. I'm just thinking of where I came from when I was a young mother and didn't have access to this information. Is like a big black hole. So to have this information, it's incredible. And so what I want to ask you is, how do you, because everybody can have a vision of what their impact is, how do you see this transforming the conversation of taking over the empowerment of a woman's body versus how it has politicized everything? Because I love how you're using science, because everybody talks about science, science, science. And you have taken this and you said, you know what, make your own decision. Now you have information in a way that is transformative. So what is your vision for the young woman here as she's starting out?
Thank you. I think that obviously there are a lot of questions built into that. One of the things that is continuously amazing, I think, to all of us, and maybe unfathomable to some of the young women in the audience, is how common it is to, for instance, meet an OBGYN who's had 4 or 5 children of her own, maybe even a grandmother OBGYN whose children have had children, and will say, I didn't know this information. When we work with our medical school partners in Africa, the students will say, we don't learn this physiology. So FEM is a gift because we learn a lot in medical school, and now we also learn the physiology, but it's the physiology that allows the medical doctor to think. Here's this patient, here are these symptoms, what is this puzzle? So you can unwrap that puzzle, try to figure out how to get to the source of what's going on. And again, that's a critical tool for an under-resourced area. We have all these smart people there ready to think, they're able to think. Giving them the knowledge and the physiology really lets them do what they know they want to do. For women, I am always amazed at how transformative this is. I think you also asked the same question. And one of the things that I would simply express is that it transforms women in ways that are hard to describe. But again, we've really seen a lot of women have said, this healed me in different ways, or this made me excited about myself, or I was really insecure or ashamed, and now I'm not. We want to give our women the confidence and the joy of being a woman, and we want to give them the knowledge and the tools to really recognize the dignity of being a woman and to appreciate and love that. And that has meant for us, as we've walked through this process, building an entire ecosystem, let's say. There's the educational side of this. There's the technology to make this accessible, free, and available. That's the app. Then the real question that we faced and the real gap that we saw was the medical side of this. But what do we do when things go wrong? And that is, I think, what we are now starting to be able to solve for. I think maybe your question, what is the impact of this? There are 2 kinds of impact. It's been raised already. There's the local and the immediate. The most impact for us is that we treat a patient and that patient feels better. They feel restored. There are so many ways that feeling better and feeling restored can manifest themselves. But happy patients is our first goal, our first impact. And what we've seen is we have happy patients. We have patients, and they're happy. They're getting the outcomes they've wanted for a long time, and they're bringing their friends. Every patient we serve usually brings 2 or 3 more patients. This is why our wait list is such a mess. But it's a wonderful mess to have because it tells us our patients are happy, and they want their friends and their family to receive the same kind of care. That's the highest endorsement, and I think all of those individual women are the women who will ultimately make the case to their own families, to their own communities, about what they think women's health and women's health services should be and should include. That's an absolutely necessary step for moving forward. Women are the people, they are the center point of health in a family, and they are the center point of health in a community. So when women find something new that they know works, that they know is a gift, and that they want their own families and communities to have, they're powerful advocates who bring those ideas forward. And secondly, we're seeing the same kind of response to these institutions that we're collaborating with. Institutions that are saying, let's work together and bring this to our students, like Providence, nursing schools and medical schools here in the United States that are starting to look to bring this knowledge as electives for their students to have the choice to opt into. And medical schools in Africa, in Asia, and in a few other parts of the world that are starting to integrate this into their own schools, recognizing that they don't have, let's say, the most cutting-edge technology, but they can certainly provide the most recent and the most complete knowledge we have, and this is the greatest gift that they can integrate into the medical and clinical way that they train their providers. So I think medicine ultimately moves forward because women and families want something that doesn't exist and can partner with medical providers who say, that's a wonderful thing, I want to work with you to give that to you. If we can forge those partnerships and move those side by side forward, I think we'll start to see very significant impacts here and in many other locations.
Hello, everyone. Thank you so much, Anna. Just a very quick announcement before we wrap up. So if you are a nursing student, I'm sorry to exclude others, but if you are a nursing student, we are having a brunch with Anna Halpine tomorrow morning at 10 a.m. So if you aren't already on the guest list for that and you're interested, come see me during the reception. We have just a few seats left, so it will be first come, first serve, but please come see me if you're interested.
And with that, I think you should give a warm round of applause to Anna.